I think we're at a really exciting time for bone health. By eliminating senescent cells, can we not only have a beneficial impact on bone health, but also impact other tissues and systems, for example, muscle or cardiovascular health or renal, liver, and neuronal health are all things that we're incorporating into some of our new trials.
Welcome to the Joint Space Podcast, brought to you by the University of Arizona Arthritis Center, one of the first 4 centers of excellence in the University of Arizona College of Medicine, Tucson. The mission of the Arthritis Center is to make a difference in the lives of patients and their families by conducting research ranging from molecules to people, by empowering patients to take charge of their lifestyles, and by educating clinicians and scientists to enable compassionate care and the delivery of novel, effective, and safer therapies. Hello, my name is Tracy Shake, and as Director of Community Outreach and Education in the Arthritis Center, I welcome you to the latest episode of the Joint Space Podcast. In the show, we explore a wide range of health and wellness topics with some of the most respected experts and brilliant minds who share the latest research, clinical care, treatments, and medical innovations to help patients discover new pathways to health and wellness. We're joined today in the Joint Space Podcast by Dr. Josh Farr. Dr. Farr is Associate Professor of Medicine in the University of Arizona College of Medicine, Tucson, and holds the Ethel McChesney Bilby Endowed Chair in Osteoporosis. Today, we are discussing the ABCs of osteopenia and osteoporosis. Welcome, Dr. Farr.
Thank you.
We're going to start basic. So we're hoping that you can define for our audiences give us the definition of osteoporosis and explain to us how it differs from osteopenia.
Sure. So yes, I've been working in the osteoporosis research field for the past 15 years, and the definitions can be a little confusing. So at its bare minimum, the word osteoporosis is actually from a Latin term. Osteo means bone, and porosis refers to porous bone. And so literally it means porous bone, or in lay terms, low bone mass. Osteopenia, again, has Latin underlyings, osteo meaning bone, and penia means low. And so these are terms that are used for individuals who tend to have lower bone mass or bone mineral density, which is abbreviated BMD. So that's kind of the simplest definition. The more clinical definition of osteoporosis and osteopenia is derived after getting a bone density test. And so this is done using a technique called dual energy X-ray absorptiometry, or DEXA, where the individual who's getting the test done will lie on a table, and underneath that is a detector, and a low amount of energy will pass from an arm that goes over the body while the individual is lying there, and it will pass through the bones and other tissues. And based on how much energy is absorbed by the DEXA, it will be able to determine the bone mineral density of different regions of the skeleton. And so this becomes useful information because we can plot that data for a particular individual and compare it to the population. And in this case, what we typically do is compare to a younger, healthy individual of the same sex. So females are compared to female and males with males. And so when an individual gets a DEXA scan, they'll get a readout of their bone mineral density and what's referred to as a T-score, which is a standard deviation comparison against that young, healthy individual who has average but optimal peak bone mass. And this typically occurs during young adulthood in either the 20s or early 30s of the lifespan. And so that T-score is based on a standard deviation difference between your individual bone mineral density as compared to that individual. So in other words, a positive T-score would mean that you have a bone mineral density that's higher than that younger average individual, whereas a negative score would reflect a lower bone density. And so clinically, a T-score between -1 and -2.5 is defined as osteopenia, that is the low bone mass or low bone mineral density range. And so those individuals are at risk for fracture, whereas individuals who have a T-score of -2.5 or lower are defined as having osteoporosis. And the reason why we use the DEXA is because it's really, at this point, the gold standard for measuring bone density. And although we have some more advanced tools that we can use to image the bone and look at the bone microarchitecture in different regions of the bone and different types of bone in terms of trabecular and cortical bone, we really don't have a marker in the blood or in the urine in which we can accurately predict what your risk is for fracture based on that systemic circulating marker like we would, for example, for cholesterol as it relates to cardiovascular disease. In the case of osteoporosis, this bone density score is one of the best measures that we have, and it's widely available clinically. It's relatively quick and easy to complete. It only takes about 15 or 20 minutes to get scans at different regions, which typically include a whole body, a hip, and a spine.
So since many don't hear about osteopenia or osteoporosis until they're, say, over the age of 50, and then you start to hear quite a bit, whether it's a reference from a physician or what we hear in the media about the commonality of osteopenia and osteoporosis. So many find out about it, learn more about it when it's too late, when they already have osteopenia or osteoporosis. So if you could share what you as a scientist and healthcare providers would like people to know at an earlier stage, what the risk factors are. We'll talk later about, what lifestyle changes can be made, but what are the primary risk factors that people should focus on in order to prevent getting osteopenia or osteoporosis?
Right. So as you mentioned, a lot of people will eventually develop osteoporosis because it's a very common disease, and they might not know that they have it. And that's because screening typically, isn't covered by insurance until this older age. And so it's not something that's done routinely earlier in life. But in terms of risk factors, the main risk factors are age. So older age is probably the greatest risk factor for osteoporosis. Sex is a risk factor, and that can relate to a number of factors that are related to sex. So, for example, females tend to have smaller body sizes. They tend to have lower body weights. And with that lower body mass index, or BMI, their skeletal frame size and the shapes of their bones are smaller, and therefore smaller bones tend to be more susceptible to breaking as compared to bigger bones, which have more geometrically favorable shapes to resist forces and thus have more and better resistance to fracture. There's also a sex difference between boys and girls during development. Girls reach puberty earlier than boys and start to get that increase in height. Boys will come on later and the puberty will last longer. And so their bone mineral density, males, will tend to be higher during early adulthood, even though they'll reach that a little bit later than the females in terms of their pubertal development and the optimization of their skeletal structure. So in terms of what we refer to as peak bone mass or peak bone strength, which is not only dependent on the mass and the density, but also the structure of the bone, that's typically achieved, as I mentioned, kind of in that second to third decade of life. And males tend to have a higher optimal peak bone mass threshold as compared to females. The other major risk factor when it comes to sex is related to sex steroid hormones. And one of the most important in women and in men is estrogen. And so around the fifth decade of life, women will go through the menopausal transition, and this results in a dramatic reduction in estrogen levels, which in turn activates some of the cells that are responsible for breaking down bone. So there are signals in response to the absence of estrogen that are sent to cells that are called osteoclasts, which are responsible for resorbing or breaking down the bone. Those cells become more active, and the cells that are normally responsible for maintaining bone, the osteoblasts, which are the bone-forming cells, they're not able to keep up with the activity of the osteoclasts, and therefore there's an imbalance that shifts towards resorption over formation and what's referred to as a negative bone balance, which occurs typically during that menopausal transition, where you get a much more accelerated bone loss, which then starts to level off, but still results in an imbalance with aging that again favors resorption over formation. The other major risk factor, which we really can't control, again, these are all primary risk factors that are beyond our control, is our genetics. And so that can, depend on your ethnicity, on your race, and different people from different backgrounds are going to be more genetically susceptible to having higher or lower bone mineral density or bone structure. And there are genetic differences in the structure and shapes of bones that can also put individuals at risk. So all of these factors kind of collide together to create a unique scenario for individuals to relate to their primary risk for osteoporosis.
We know, unfortunately, that one of the symptoms of osteoporosis is a fracture. I don't know if you can actually call that a symptom, but a result. Mm-hmm. Are there any other symptoms that people should look for that may be a predictor or tell them it is time for a DEXA scan or to be analyzed for osteopenia or osteoporosis?
It's a good question. It's actually quite variable from individual to individual. Oftentimes, osteoporosis is referred to as a silent disease because many individuals in the population will have osteoporosis and not even know it. So there are many, many men and women walking around who just don't know that they have osteoporosis. They don't have any signs or symptoms or anything that would signal to them that something's wrong. There are a few that will experience, in particular in the spine, in what are referred to as the vertebra. These are the bones that make up the back, and particularly in the lower back, when we lose the cartilage in between those vertebral bones, that can result in bone-on-bone pain, and that bone-on-bone can also be due to loss of bone, which causes the vertebral column to collapse, and in certain areas can cause curvature of the spine, which is clinically referred to as kyphosis. So that loss of height, which can be due to the compression of those vertebrae, which often occurs with aging, the kyphosis of the spine, and oftentimes that back pain can be symptoms of osteoporosis that might signal that you need to be checked.
So as women, of course, I think we are more aware of osteopenia and osteoporosis, but certainly we know that it's not just women that are impacted. Can you talk about how common osteopenia and osteoporosis are in the U.S. population? You mentioned it's not uncommon. What do we look like as a country as far as numbers, and do we differ from, say, European countries? Is there a higher prevalence here or elsewhere? Just curious about that.
Mm-hmm. So, yes, osteoporosis and osteopenia are both very common in the U.S. There are currently well over 10 million women alone in the U.S. who have been diagnosed with osteoporosis, and that doesn't count all the women who have not been diagnosed. The number of individuals with osteopenia is even higher. So we're talking about millions and millions of Americans. Men are at risk too. And as you mentioned, the ultimate, worry is that with osteoporosis, there's an increased risk for fracture. And so in terms of statistics, women over 51 and 2 will typically experience an osteoporotic fracture in their lifetime, whereas it's about 1 in 5 men. So, but when you think about that, 20% of all men, that's a lot of the population. And the US is no different than many other countries around the world. We're a very diverse population with people from various ethnic backgrounds. And so the US, I would say, is fairly average in terms of osteoporosis and osteopenia. There are some countries that may be a little bit more or a little bit less at risk, or the prevalence might be a little bit different, but that can also be related to other factors such as screening and availability to DEXA and things like this. So this is a worldwide problem. It's not just something that affects Americans. And so it's very common in Europe and other countries throughout the world.
Are there other medical conditions outside of what we know many of the risk factors are that you've discussed earlier? Are there other medical conditions that predispose somebody to osteopenia or osteoporosis, including medications that somebody may take for another condition?
There are quite a few. These are referred to as secondary risk factors for osteoporosis. And so there are a number of diseases or conditions that can negatively impact the bone. And that's because we're learning more and more through research that our tissues and different organ systems are all connected to one another in various ways. And the bone is obviously throughout the entire body, throughout the skeleton, and therefore it's in close contact with many other tissues and systems. And so there can be, for example, things like diabetes or kidney function problems or liver or gastrointestinal issues that can negatively impact the bone because those organs and systems are maybe producing hormones or maybe producing different factors that are important for the bone. Another major one that a lot of times people don't think about is skeletal muscle and the loss of muscle that occurs with aging, which is sometimes referred to as sarcopenia. Sarco, again, is another Latin term which means muscle, and penia means low. So this is low muscle mass. Muscle produces a lot of proteins and signaling factors that communicate with the bone in order to maintain proper bone cell function, in particular those osteoblasts, which are responsible for forming and maintaining the bone. And then there are other things like cancer or other medical conditions like arthritis that require certain types of treatments or medications that are important and that your clinician, your healthcare provider will encourage you to take and that you should adhere to in order to help with either your cancer or your arthritis or whatever condition that you have. But sometimes these medications can have negative consequences for the bone. And so one of the most common examples, for example, in patients who have arthritis, one of the big ones is rheumatoid arthritis. It's oftentimes treated clinically using glucocorticoids, which are important for reducing inflammation and helping the joint. But when prescribed at very high doses or for very long durations, those can have a negative impact on the bone. And so that's not to say that they shouldn't be taken or that they're bad, but really what needs to be done is working with the team of clinicians in order to try to either limit the dose or limit the exposure to those types of medications, and keep in mind that the bone health is something that could be affected.
Well, we've talked about risk factors and what can contribute to osteoporosis. So now let's pivot a little bit and talk about what things can be done to hopefully prevent this condition. Lifestyle changes. Let's start with dietary factors that might be able to impact bone health.
Sure. So really what we're learning more and more is that a well-balanced diet is a really important part of bone health, and really in terms of maintaining health of a number of organs and different tissues and systems. And when it comes to bone, getting adequate amounts of protein is very important. The two main factors that we get from the diet that are important in maintaining bone, in addition to protein, are vitamin D, which we do produce in our bodies in response to getting sunlight, or there are enzymes in the kidney and liver that can help to produce vitamin D, but the diet is another important source. And that can come from a number of different types of foods, not only dairy, but also certain types of fish or different types of plants and vegetables can be important sources of vitamin D. The other really big one for bone is calcium. And that is because calcium is a major component of the hydroxyapatite crystal that helps to mineralize bone and maintain its heart structure. And so we want to make sure that we're getting enough vitamin D and calcium, but most people, if they eat a well-balanced diet, will be able to achieve that. But some will not, and they might be lactose intolerant, or they might not be able to have certain types of foods. And so in that case, it is important to supplement with a multivitamin or talk to your healthcare provider about taking vitamin D or calcium and as a supplement in order to get adequate amounts. So we want to make sure that we're getting enough, but there's also too much. So too much in this case is not necessarily a good thing. So we want to maintain calcium and vitamin D levels within the normal range. Most people can get that from their well-balanced diet. Some will need to supplement in order to achieve those goals.
So a question that often comes up when we're talking about diet is, for someone who doesn't get it from their daily consumption of foods that contain calcium or vitamin D, is taking a supplement as effective as somebody getting it naturally in their diet?
So I think that, the supplements, as I mentioned, they can definitely help those who aren't getting it from their diet. But taking many supplements, thinking that this is going to, make a difference. If you're getting that well-balanced diet, you're spending a lot of money, and this has been looked at in terms of the costs that are spent on these types of things. You're really spending a lot of money to not get any real benefit in terms of health. So getting enough is good enough, and getting extra doesn't give you extra credit or make your bone even better. The staying within that normal guideline is really where we want to be. And, sometimes taking those supplements can put you at risk for being too high, which can cause other health problems and be problematic. So it's something to keep an eye on.
So would a patient be able to ask their healthcare provider to add a lab test? I know certainly for vitamin D you can. Can that be done for calcium as well? Or how is it determined if someone is getting enough, if you're able to answer that?
Yeah, so both calcium and vitamin D can be measured very routinely clinically. So that's something that can be monitored. If you are vitamin D deficient, definitely need to talk to your healthcare provider about ways in which to get that back up. And then obviously you can come back in and get that rechecked very easily. And usually, with a supplement, that can be achieved.
So we're talking about what types of changes can be made as we attempt to achieve a healthy diet. So let's change that subject now into what type of an exercise routine can be impactful for bone health. What would you recommend as far as what could make a difference before somebody is diagnosed with osteopenia or osteoporosis?
So yeah, we're learning that bone is actually a little bit unique in terms of a tissue as it pertains to exercise. Bone is a tissue that if we don't use it, our bodies think that we don't need it. And that's really comes from an evolution and adaptation perspective in terms of the biology. The bone is something that is constantly throughout life being broken down by the osteoclast and then repaired by the osteoblast. So it's the way to think of it is kind of like sidewalk, like concrete. It develops these cracks and small little cracks that then can get bigger and bigger, and that can spread to other regions of the sidewalk. And over time, it becomes very brittle. Well, in order to prevent that, our skeletons have adapted in a way to constantly be breaking down the old bone through osteoclastic bone resorption and replacing it with new bone in a process called bone remodeling. And so that remodeling cascade is very important to maintain bone. And one of the major stimuli in order to activate that remodeling cascade is a dynamic stimulus or force that acts on the bone. And so there are cells that reside within the bone. The most common and prevalent type of cell in bone is called the osteocyte. And these cells have projections that extend from one another and allow for communication between adjacent osteocytes and also communication to the osteoblast and osteoclasts on the bone surfaces. And really the osteocyte is kind of like the neuron or brain cell of the bone, in that it responds to fluid shear stress that passes along the osteocyte in response to forces. And so when that fluid shear stress passes from one osteocyte to another, those osteocytes will activate signals to the osteoblast to stimulate new bone formation. And so in the absence of those signals, the counter actually occurs to the osteoclasts, where they actually become more active and we start to resorb the bone. So for example, this is an issue in individuals who go up into space because there's no longer gravitational forces, and without impact on the bone, we will activate that osteoclastic bone resorption mechanism. There will be an absence of signals from the osteocyte to the osteoblast to stimulate bone formation. And so those individuals will experience very rapid bone loss. And so NASA and other places are trying to do a lot to help deter that bone loss through things like exercise. And so one of the main types of exercise that's important that we're finding is the higher impact or higher weight bearing exercise. So for those individuals who can, resistance training, higher loads are more stimulatory when it comes to bone formation as opposed to things like swimming or cycling, which are very important and great for cardiovascular health and endurance, but aren't going to have as much of a stimulus to cause bone formation. And so when it comes to bone, really getting those high impact stimuli, particularly during growth, when the bone is changing very rapidly in terms of its size and structure, that's a very critical period when the bone is adapting, and then maintaining that throughout the lifespan and especially into old age. Now, when it comes to exercise, one thing to keep in mind is that with these kind of high impact or resistance training programs, there is a risk for injury. And so people need to be aware of that and, not to jump in too fast or without, proper education on how to do those types of techniques. So talking to either a physical therapist or a trainer on how to incorporate a high impact osteogenic exercise loading regimen to help your bone health is something that's very important.
So say somebody has been diagnosed with osteopenia or osteoporosis, and short of going on medication, if they are to begin to or continue to incorporate weight-bearing exercise, higher loads, the things that you're referencing, can bone density be improved? We're talking without medication, with lifestyle changes. Can there a change be made if new modalities of exercise that can be impactful to bone health are incorporated into lifestyle?
Mm-hmm. So the answer is yes. And it does depend, however, on a number of factors, one being age. The skeleton, as we get older, tends to be less responsive to these mechanical signals. And so our bodies, our bones become less capable of responding as they were when we were younger. And so that's why that exercise regimen, particularly during growth and puberty, when the bones are changing very rapidly, that's the most optimal time. And what we found through research is that by optimizing the skeleton during that kind of critical window of opportunity where the bones are changing most rapidly, that's when you can get the most skeletal gains. However, there have been research studies using weight training and different types of high impact exercises in women who are going through menopause or even in postmenopausal women. And that has been shown to increase bone mineral density even on those without medication.
So the hope would be certainly to make a change without medication if that's possible. When that isn't possible, can you describe the, sort of the first course and then what people can expect if they are over that T-score where medication is indicated?
Right. So this is where, you definitely want to talk to your clinician and your healthcare team about, what can be done. Starting to getting that your T-score and determining your risk for fracture can really open up a number of different avenues for treatments. And this is where, the clinician, depending upon the individual, might encourage going on an osteoporosis therapy. Historically, a lot of women in particular, because of this rapid bone loss that I mentioned during the menopausal transition, were taking hormone replacement therapy. That has changed because of some of the results from the Women's Health Initiative, which documented that HRT actually increased risk for things like cardiovascular disease and stroke and breast cancer. And so, and that's not to say that there aren't caveats or reasons for why that might be the case, which I don't have time to go into, but a lot of physicians are transitioning towards using osteoporosis specific medications. There are a number that are available and that are very effective. So that's the good news. They're basically broken down into two major classes: the anti-resorptive medications and the anabolic therapies. The anti-resorptives are probably the kind of first line of defense that are prescribed for individuals either with osteopenia or osteoporosis. And again, it depends on the individual scenario. So your T-score is not the only factor. Your doctor will take into account a number of different risk factors, which all get combined into making the decision. And so it's an individualized medicine-based decision. But oftentimes, the first line of defense is the bisphosphonates. There are 4. These are drugs that get embedded in the bone, and then when the osteoclast comes to do its job of breaking down that old bone, the bisphosphonate, which is a drug, gets taken up into the osteoclast, and it activates a programmed cell death mechanism called apoptosis, which kills the osteoclast, and so you get lower bone resorption, and it slows down the bone loss. There's also a newer drug that targets osteoclast. It's referred to as denosumab, and it's marketed as Prolia. Denosumab works through a different mechanism. It's a human monoclonalized antibody that binds to a protein on osteoclast called rankligin. And it actually prevents osteoclast precursors from developing into mature osteoclasts. And so that drug really reduces the number of osteoclasts and can slow down that bone loss. So those anti-resorptive drugs are typically kind of the first line of defense to slow down that either menopausal or age-related bone loss. For those individuals who are even at higher risk for fracture, maybe those who have sustained one or more fractures, oftentimes physicians will go with anabolic therapy for a short period of time. The main classes of anabolic therapy are the PTH analogs, paratherapide and abaloparatide, and the sclerostin inhibitor romosozumab. The PTH analogs were discovered many years ago, actually by accident, but work in a way in which, when administered intermittently, can stimulate the osteoblasts to increase formation. Now, they also stimulate the osteoclasts, but more so the osteoblasts than the osteoclasts, at least for short periods of time. So this could be for up to a year or even sometimes 18 months. PTH, when administered in this shorter peptide form, parathyroid hormone is an 84 amino acid hormone. PTH, when administered as teriparatide, for example, is only the first 34 amino acids of that protein, and when administered intermittently can have this overall anabolic effect to stimulate bone formation. The newer drug that has been marketed as romosozumab by Amgen is called romosozumab. It's more expensive. It works through a different mechanism that targets a protein that's produced by the osteocyte, these cells which are embedded in the bone. That protein is called sclerostin. And again, romosozumab it's a human monoclonalized antibody that binds to sclerostin. And what you can think of sclerostin is like in a car, the brakes on bone formation. And so when it binds to its receptor, it actually decreases the Wnt signaling pathway in osteocytes and osteoblasts to reduce bone formation. So it's putting that stop signal on the brakes. When we administer romosozumab, that antibody binds to sclerostin and prevents it from stepping on the brake. So it's essentially taking the foot off the brake, which in a way results in an anabolic effect. What's unique about romosozumab is that it also, in a short period of time, can have an anti-resorptive effect. So you get a dual anabolic and anti-resorptive effect, which causes significant increases in bone mineral density that in studies have been shown to be superior to both teriparatide and alendronate, which is one of the bisphosphonates that's commonly used clinically. So there are new osteoporosis medications that are being developed, romosozumab being one of them, but cost is an issue. There's also been a few phase 3 clinical trials which have shown that individuals who have received romosozumab have a very small but statistically significantly higher risk for cardiovascular events. And so it's not currently prescribed for individuals who might be at risk for cardiovascular disease. So there's a lot to kind of digest there and keep in mind, but once individuals are on anabolic therapy, what we do know is that anabolic therapy is only effective for a relatively short period of time, whether that's a year or 18 months. But over time, the osteoblasts will kind of become used to that anabolic therapy and no longer able to stimulate bone formation. And so they'll no longer be effective, and essentially the effects wane over time. And so oftentimes these are only prescribed for individuals who are at very high risk for fracture to really help stimulate that bone formation to reduce their risk. And then those patients will transition to other therapies.
Is it possible for you to list for us, so the first line is bisphosphonates, first line of treatment, correct?
Mm-hmm.
What the non-scientific names for these drugs are. So somebody listening may be on one of these or the other. What?
So there are two major formulations. Alendronate is probably the most common bisphosphonate that's prescribed in the United States. It's an oral bisphosphonate, so you take it as a pill, but because it's taken, orally, it needs to be digested from the GI into the bloodstream and then passed to the bone. Now, there's absorption issues with that, and so it's important to take that early in the morning with water and not food, because the bisphosphonate can just be washed out with the food and other contents of the GI and not absorbed into the body, and so very little gets into the bone. And even when taken correctly, a much smaller amount is absorbed into the body and into the bone, which is the goal. So sometimes different bisphosphonates can have different formulations, one of them being zoledronic acid, which is administered by an IV injection. And it's really given much more intermittently, either every 6 months or sometimes only once yearly. And that IV injection goes right into the bloodstream. And so it's a much more potent bisphosphonate, which will then be taken up into the bone.
Since you have dedicated your research career essentially to bone health, can you tell us what you have found over the course of your research, what new developments you have seen? You said you've researched bone health for 15 years. And what are we looking at in the future? What developments are being made? What is the vision at this point in time?
So I think we're at a really exciting time for bone health because we have a lot of different types of medications that are safe and effective in treating bone loss. But how we make treatment decisions in terms of transitioning from one medication to another and when that should occur and for how long, these are really important questions in the field that are still being asked and researched in clinical trials. And in terms of why those, for example, anabolic therapies, why their effects wane over time, we actually still don't know the answers to those questions, even though some of these drugs have been around for many years. And so understanding the underlying mechanisms of why those cells, for example, osteoblasts, become less responsive over time are questions that we're still pursuing. And if we can identify those underlying mechanisms, we may be able to develop even more effective therapies that can be anabolic, for example, for longer periods of time and result in even greater gains in bone mineral density. So what's exciting is that we've kind of transitioned from bisphosphonates, which were actually discovered in 1969, over 50 years ago, to kind of these newer, more bone biology specific drugs, for example, denosumab and romosozumab, which were discovered by research and funding that was put towards development of these drugs, which have kind of widened the spectrum of drugs that are available in terms of how we can treat individuals who are at different risk for fractures.
So you returned to the University of Arizona after being a scientist at the Mayo Clinic. Can you tell us what is going on in your lab right now? I know you're working with senescent cells and looking at aging and the impact on bone and other diseases as well. So can you just tell us a little bit what a day in the life of a researcher like you, if you can tell us a little bit about that?
Well, my day typically involves a lot of, reading and working on grants and papers and writing and, meetings and interactions. But what we're, as a team working on in the lab, as you mentioned, a mechanism called cellular senescence, which is a type of cell damage that occurs to old cells that makes them dysfunctional with aging. And what I found in my lab is that these senescent cells accumulate in bone and impact a number of different bone cell types, including immune cells within the bone marrow with aging. And what we found using preclinical studies in animals and more recently in a phase 2 clinic randomized controlled trial in older women is that by treating with drugs that can target and eliminate these senescent cells, that we can have a romosozumab-like effect, a dual anabolic and anti-resorptive effect on bone, which results in increases in bone formation and reductions in bone resorption and better bone microarchitecture. And so what we're doing next is to try to figure out how often we need to administer these drugs, which we refer to as senolytics, that target the senescent cells and kill them in order to get the most beneficial effect on bone. And then we're also asking the question, because senescent cells are not unique to bone, they actually accumulate with aging and essentially every tissue throughout the body. By eliminating senescent cells, can we not only have a beneficial impact on bone health, but also impact other tissues and systems, for example, muscle or cardiovascular health or renal, liver, and neuronal health are all things that we're incorporating into some of our new trials to see that if by using a single medication to target this fundamental mechanism of aging, cellular senescence, can we positively impact multiple systems simultaneously?
It's very exciting. And we certainly hope that you will come back to the Joint Space podcast and share more about the research that you're conducting. It goes far beyond, as you were mentioning, far beyond bone health. And we look forward to learning more about that in the future. So thank you again for joining us this afternoon. Wonderful to have you. We had Dr. Josh Farr with us today in the Joint Space podcast.
Thank you.
Joint Space, where people, ideas, science, action, and curiosity come together. The Joint Space podcast is brought to you by the University of Arizona Arthritis Center. To learn more about the Arthritis Center, please visit arthritis.arizona.edu. We appreciate your interest in this show and our Living Healthy with Arthritis programs. If you enjoyed this episode, please give us a like and subscribe to our podcast on your favorite platform. Joint Space is produced by Greg Gillis with assistance from Luke Brower. Graphics were created by Luke Padway. Our theme music is courtesy of MC Yogi and John Pattern. Thank you for listening. Every step counts toward better joint health.